obviously treating knee pain is a good one because we can see the different skill sets work well together, and looking when we have to utilise each other together. So basically, I'll hopefully speed through this chat and then go through the case study with how we would treat knee pain, and then hopefully fire some questions through. So please interrupt and ask me to clarify anything. So just to start with, we're looking at how common patellofemoral pain is. Again, it's 70% of people with patellofemoral pain are in that age group between 16 to 25, and then the highest point prevalence is between 12 to 17. So it's really common problem, and it tends to fit between that sort of younger adolescent, teenage group. There's a higher rate in females, about 2 to 4 times greater compared to males. And looking at a study, it showed that 16.3 people out of 100 had patellofemoral pain at the start of the season, and that went up to 22 out of 100 in that female basketballer group. So very common in that area. Again, not particularly sure why patellofemoral pain happens, but we know it's tends to fit into the overuse injury category. Obviously that repetitive loading and sensitisation of tissue impacts on that pain experience. Interestingly, there's some studies that show that the pain threshold is potentially lower in people with patellofemoral pain. So that gets us thinking that potentially there's a chronic pain syndrome where hyperalgesia and hyperaldinia are present in that. So it's not always just a straight overload problem. If someone suffers pain for a long time, there's changes in how they process pain, and again looking at sometimes if it's not making sense from a mechanical point of view, sometimes those other factors come into it. Looking at it from a biomechanical perspective, we're looking at an increase of greater than 20% Q angle, gives you an increased risk of knee pain with running by 6 times in female girls. So again, we know that structure of what your skeleton your parents gave you impacts your ability to get pain. So we know that's something to look out for. There is conflicting evidence on the static Q angle and the effect on PFJ, and later on in the talk I'll be talking about dynamic valgus and the effect that has on the Q angle. Again, this is where I'd like to get some input from you guys. Obviously navicular drop and drift is significant in the adolescent group, and that significance that it has on patellofemoral pain. Adolescence obviously tends to be a unique time for anyone's life, and again potentially the prevalence of pain in the adolescent group has to do with the uniqueness of that time. So looking at it from a body changing point of view, we're looking at changes in the skeletal system, rapid growth, the soft tissue on generally about a 12-month lag to catch up to the skeleton, and we're thinking that the neural structures are potentially on about an 18-month lag. So when you know a 13, 14-year-old boy, for example, is playing high-level sport, he goes through a growth phase. It's potentially overloading some of the soft tissue structures, and a lot of the time it is that neural structure that often is impaired, and again it sort of gets misdiagnosed as muscle pain or growth pain, and often there's it's a challenging one to manage with those really keen athletes. Again, obviously looking cognitively, there's a lot of changes, and we know the adolescent brain's quite vulnerable to stresses, and obviously the effect of those stresses and the ability to process pain is a challenging one for any clinician. and treating adolescents when you get a nod or a grunt as an answer is challenging as well. So you often need the crystal ball to get anything useful out of them. And sometimes the parents are as oblivious as the kids. So it's quite a fun session sometimes. But you know, my knee hurts, fix it is sometimes what you have to deal with. Again, obviously, the other thing that potentially is the reason adolescents get knee pain is that risk behaviour, especially in sport, the ability to process risk, and often, you know, for the greater good of the team and saving face amongst peers would mean that if they did have pain or pain was developed, they're likely to push through that and not sort of realise the consequence. I'm actually treating a 16-year-old kid at the moment who had osteochondritis in his patella so badly that it actually ended up fracturing and becoming a loose body in his knee, and pain wasn't a problem for him, it's just his knee didn't work. So, you know, he's a really keen footballer, and that sort of greater good of contributing to the team really masked a lot of the symptoms that he had, and obviously now it's more of a, you know, chronic problem and has to be carefully managed with his load. So again, don't underestimate if a teenager is reporting pain. Often there is underlying problems that aren't just PFJ. Often it can be, you know, stress fractures. It can be another disease process which is called OCD, osteochondritis dissecans, where the cartilage in the knee potentially doesn't form properly, or the blood supply to the cartilage in the knee is impaired, and with continually loading, that cartilage gets damaged as well. So again, it's a challenging area because you know, there's two ends of the spectrum. Some people with impaired pain processing, and you know, it's the normal pain anyone gets from running, and then the other side where you know, they're ready to run if they've got a fractured leg or dagger out of their leg anyway. So it's difficult. Some injuries that are specific to adolescents, obviously osteochondritis. So again, we're looking at that as explained as an overuse injury to the cartilage. So when anyone does exercising, you get load through the cartilage. There's a normal amount of wear and tear to that. Obviously your body has the ability to heal itself, but if there's continual loading between those healing time frames, you get that sort of micro trauma on micro trauma until it turns into a injury, and that's obviously what we think happens. Vulsion fractures are common. Obviously the growth plate injuries, the Salter-Harris fractures, obviously looking up in the spine, scoliosis and Schumann's disease tend to show their face in that age group as well, and again, it's looking at obviously, you know, the person in a whole person view, and making sure that some of these things that are managed better the earlier they're picked aren't missed. Okay, looking at the basic anatomy, obviously there's 4 directions that the patella is stabilised. One of the big theories of why people get patellofemoral pain is the lateral tracking of the quadriceps, or of the patella, sorry. Again, we're looking at the shape of the trochlea and the shape of the patella being one restraint, but you've also got the soft tissues on the lateral side, which is the ITB, the lateral quadricep, the inside dynamic structures like the vastus medialis, and again, obviously, distally and proximally held in by the patellar and quadricep ligaments. So again, you can get a rough feel of the tightness of those different structures by gliding the patella, and that's something I'd hope to show today. Often with someone who's getting pain, you might find that there's a restricted glide medially because of tight lateral structures, or actually when you glide it medially, the patella tilts because of those structures are tight. And again, it potentially has something to do with why they get pain, but no one's exactly sure. Okay. Now the patella makes contacts to the trochlear groove at different areas. Okay, so often you'll find people have symptoms, at 30 degrees knee flexion or greater, and often you can see, if it is the cartilage or subchondral bone that's painful, potentially you can get some information where in range that they're getting it. There's a test that physios do called McConnell's test, where we're resisting a quadriceps contraction at different ranges and looking where their pain is, and then applying a medial glide to their patella to see if that influences their pain. And it's a really good prognostic factor that general quadriceps strengthening is going to help them if they have a reduction in pain with the onset of that medial glide. And that's a very simple test. Okay, so again, looking at that contact, the more load that someone does, potentially running compared to jumping off height, the patella would make more contact in the groove, and that's related to the shape of the patella. Higher contact, you get more articular contact, and that load is spread through the patella over a greater surface area. So there's no one point that's getting too much contact. What we think, obviously, is the patella's, this is going to confuse me, I think that's the lateral side. That would be lateral side because of the shape of the trochlea. Potentially the kneecaps drifting out laterally, you're getting more loading on that side of the trochlea and more loading on the lateral side of the patella, and relatively you're getting a extra load through that articular cartilage, enough to cause it to react. Often you see people with patellofemoral pain, but they've got symptoms medially, and you go, what's that about? But they don't have anything laterally. Could be from the soft tissue restraints. So you're looking at the medial patellofemoral ligament as being stretched when they exercise, and obviously that soft tissue structure can become inflamed, sensitized and painful. Obviously you've got the synovium of the joint as well, and medially the saphenous nerve that can obviously react if there's inflammation in that area. So again, it's not always from the articular surface. We think a lot of the time it's actually the soft tissue around, and if it is articular surface type pain, that's when you're looking more at that chondral reaction, and obviously that into overuse injuries, stress reactions, stress fractures, and obviously you look at that as a more severe sort of case of that pain. So it sits on a spectrum from a little bit of soft tissue inflammation and symptoms to obviously the full-blown, subchondral bone reaction, impaired blood flow to the cartilage and the consequence of that, and potentially obviously osteoarthritis as a longer-term consequence. Okay, basic mechanics help you understand why people get pain. The 90% of the people you'll see with knee pain, it's a very mechanical loaded pattern. So it hurts when I do too much. When I rest it feels good. It hurts when it doesn't hurt when I'm walking, but when I'm walking downstairs it does. So there is that general cause and effect. And we think that has to do with the resultant force that the patella exerts on the knee. Obviously that sort of shows it there well. The patella actually gives the angle of the knee a larger, fulcrum to exert more power on the knee. So obviously the quadriceps force causes the tibia to go forward in a closed pack position. That's how you propel yourself, and obviously that resultant force is down into the knee. Something like walking, you're looking at 1 to 2 times your body weight as a resultant force into the knee. And again, with things like running, you're looking at 6, going downstairs, about 8, landing from a jump, 12, and then powerlifting or squatting big loads at 90 degrees where that peak force is, it can be up to 25 times your your body pressure straight through your trochlea. So it's big forces, and you can often tell your fat patients to lose weight because it's a multiple of the weight that they have. So if someone's getting activities or pain with activities like running, if they lose 5 kilos, you're looking at that as being 5 times 8, so 40 kilos less loading through their patella when they're doing that. So it can make a significant difference, a couple of kilos on those sort of overuse injuries. And hopefully don't call them fat. Maybe say that their weight may be an issue. I'm not sure how you can politely say it. I have trouble with it. I also have a dietitian working with me, so we refer them on. Okay, what else have I said there? Yeah, so again, obviously one of the theories is that maltracking, that subcondylar degeneration, and obviously leading to pain has been a cause. Okay. The pathology of this typical case is what we think is a periarticular synovitis. So we think there's an inflammatory aspect to the pain. Obviously, tissue overload, you get inflammation, you've somehow messed up the homeostasis of the tissue, you get that obviously effect of healing, the white blood cells coming in to heal, sensitizes all that tissue, part of the healing process. Again, we're thinking that becomes a chronic thing, so it gets inflamed, heals, doesn't get rested enough, gets inflamed, and then obviously it turns into a bigger issue. Looking at obviously the mechanical loading of that soft tissue, as I've already talked about. Okay. Now, anterior knee pain and patellofemoral pain tend to get grouped in together. So again, there's differences. I guess the main thing is if there's any trauma, direct load to the patella, instability or suspected dislocation or subluxation, it's pretty clear in the history, and that's not normal for patellofemoral pain. So again, if there's anything that's sort of anything out of the ordinary, you should ask for other questions. If there's any swelling straight after, we'd always think of potentially that hemoarthrosis being present. And again, with kids, they can fall on their knee, and that sort of kissing injury of the patella into the trochlear groove can cause a big bleed in the joint, and you generally see that as a big swollen knee rather than, oh, my patella hurts when I run. So again, often grouped into patellofemoral pain, but there is specific diagnoses. Other differentials are still obviously overuse injuries, so Osgood Slatters, very common one as well in the younger age group, but again, you think that pain is going to be more distally on the tibial tuberosity. You've got the patellar tendinopathy. The OCD, as I said, is actually quite common and probably misdiagnosed as patellofemoral pain. And again, a lot of the time, if patellofemoral pain's not responding to conservative measures, an X-ray can rule that out. And again, if it's still not responding after X-ray and the X-ray was clear, often you have to go to MRI. Again, loose body does happen, and you're just looking for, I guess, locking of the knee, clicking, cracking, things that aren't just a normal crepitus on the knee joint. And again, that could be a loose bit of cartilage. And then obviously, more commonly now, more understood, OA, and this can obviously happen in younger athletes as well. So it's not uncommon for a 30-year-old runner to have OA in his patellofemoral joint. It is obviously a clinical diagnosis, and all the symptoms have to match, with their subjective radiological findings. And again, you'll see it'll be a little bit different if there's joint surface changes. ITB syndrome, similar mechanism. Again, if you've got that overload, lateral structures can actually get inflamed as well. Again, it's quite a different spot. If someone's getting patellofemoral pain, often it will refer laterally, but it doesn't refer as laterally onto the ITB. So it's sort of a hard area, and often they coexist in people that like to run a lot. Medially, again, don't miss any MCL sprains. Pezan-Serrano bursitis, again, basically is a lot lower. So again, you'll find the palpation is helpful to say, is it this structure or that structure, and you can get a lot of information from where they're sore. Posteriorly, very uncommon for patellofemoral pain to be felt posteriorly, but again, sometimes that pain of loading the knee can change the sort of running style, and people often develop hamstring tightness or tendinopathies as a consequence. Different process, but can happen. Okay, now findings, the typical things you'd see is pain on the anterior knee. Crepitus is a normal sensation, and make sure that's educated to your patients. If it's crepitus with pain, that's not normal. And again, basically what we're told is you've got about 5 mils of articular cartilage on your patella and your trochlear groove, so you've done well to wear that out. Again, the crepitus is probably coming from the wearing of that articular cartilage at different rates, and as those surfaces run over each other, you do get those little clicks and sounds. Again, generally you'd think the worse the crepitus, the worse the articular damage would be, but there's no correlation between how much articular damage someone has to the pain that they have, so it's sort of a hard one to justify. But if it's not sore and the knee clicks, that's normal. Aggravating factors are obviously that loaded knee flexion, and again, really fits with that mechanical pattern. The more load, the more pain. It can be swelling post-exercise, but it would be minimal. If you're getting a lot of swelling, you'd be looking at more of a chondral issue that's causing that to react. Often there's changes in their load. Someone's just started running, someone's changed shoes, someone's started running on hard surface as opposed to the grass, and it does react. The other sign that's a big sign for the pain is moviegoer's knee. So if you're getting pain in your knee with prolonged flexion, it tends to be something in the patellofemoral joint that's aggravated. Again, often the irritability of the knees, a tricky one, because you can get someone that is only sore at the last 10 minutes of their footy match, and you assess their knee as much as you can, and you just can't find anything. And it's often related to that very low irritability, and it may be related to the postures that they're putting their body in when they're fatigued. And again, you can see the changes in running style, the capacity to land and hold yourself when you're tired. That obviously adds load to the knee joint. So again, often that sort of endurance is a big thing, and is a hard one to treat when someone has very low irritability. And you often see that in the more professional type athletes, that they get pain at the end of the match. Okay. Now, I think these pictures explain what we're talking about with dynamic valgus. Okay, so again, physios, we're looking at treating the control of movement, looking at the understanding of how someone loads with landing, running, jumping, and looking at optimizing their biomechanics to absorb the load through their whole lower limb. I guess, sorry to generalize, but physios go on about the hip too much. But again, it's the combination of the hip, the foot, and the strength around the knee that we think contributes to why someone lands like this or lands like that. Okay, so what's happening here? You've got weak hip abductors and hip extensors, so you're looking at the muscle groups of the glute max and glute medius. As someone single leg squats or lands, that lack of control means that the hip adducts and flexes. Okay, it puts that knee into that position where you're stretching the medial structures, and you're also compressing that lateral joint to the patella. And again, if someone's running in each step, they're getting that dynamic valgus, there's going to be consequences down, obviously, to the foot. Again, and same thing, if there's poor control and foot posture, there's consequences on how they're loading through there. So again, we're generally looking at treating the hip, treating the quadriceps to fix this. So as I said there, the dynamic Q angle is that dynamic valgus, and I think understanding that concept with training load and picking the people that have central sensitization or chronic changes makes it easier to understand the people that you can help and the people that you can't. The other thing that's a theory is the poor control of the glutes, especially with running, causes an increase in contraction in the quads, okay? And that increased contraction in the quads means that you're getting more load through the knee, more sensitization. So again, when I was a new grad physio, I think I missed the PFJ lecture actually. I think I just used to tell everyone that their VMO was weak and just strengthen their VMO up. And I still remember cases of people with massive VMOs and massive quadriceps, and I kept telling them that their legs were weak and they were scratching their heads and looking at me oddly. So again, it can often be that overactivity of the quads because of more proximal weakness or lack of control that causes that overload there. And we really think that this is the sign, and often the cause of the problem relates higher up, and it's obviously that absorbing load through your whole kinetic chain. And if there's somewhere that's impaired, whether it's the foot, whether that's the knee or the trunk or glutes, it's going to have a consequence somewhere in the body, and often the kneecaps are the first one to show it. Okay. Now obviously non-local tissues that you can treat. Obviously we know dynamic Q angle is increased by pronation. Often that loss of dorsiflexion with muscle length changes, especially through the adolescent growth cycles, does change the posture that the knee goes into. So if someone's got lack of dorsiflexion, it's going to change where the knee tracks when they're running, pretty obvious. And then obviously the poor control through the hip in obviously that frontal plane where you fall into flexion and fall into that adduction. Local tissues, if someone has tight ITB or lateral retinaculum, it's going to cause that patella to track laterally, and again the poor imbalance between the muscle groups. So you've got one strong muscle often pulling laterally and one weak one trying to centralize it, often that imbalance. And then sometimes if someone's had an instability or they've had a bit of a subluxation through the patella, you might have that lax medial retinaculum or medial patella ligament that doesn't hold the knee in. And sometimes you just get people with really shallow grooves in their knee, and their kneecaps tend to flick around a lot, and sometimes it's a difficult one to treat because you can't change that a lot. Okay, I'll just quickly speed through this, but we'll go through that as in a practical. So generally the most information you get with this sort of assessment is watching them do the tasks that aggravate them, and I guess working on your theories of how you can fix that. So generally you rule out all the other problems, and with the kids you just have to rule out any hip pathology or any back pathology. So the two ones you'd want to rule out is Perthes and the soft. So generally you'll see them when they're walking. Quick hip range of motion should pick it, but often those can just be felt in the knee. But generally once you've ruled out any specific problem in the knee, you're looking at the patella as the last thing. So it's often a diagnosis made by exclusion. So you've ruled out any meniscal tears, any instability of the knee, and you go, well, what's left is the patella, so it must be that. Okay. And as I said, sometimes there's injuries that cause patellofemoral pain, like the osteochondritis dissecans, but it's a specific problem rather than just a pain from it.